So the first talk that we're going to discuss today is ankle trauma, and we'll start with a review of ankle foot with ankle structures, including bones and the ligaments for the most part. We'll look a little bit at imaging features, we'll discuss classifications, and if there's a take-home point for most of what I'm talking about today, it's that there's a language that orthopedic surgeons use that we sort of know, but not at the same way that they talk about it. And if you've worked with orthopedic surgeons, and are there any orthopedic surgeons in the room? I'm doubting so because it's after lunch and it's sunny out. But they are a fickle group. I love them dearly, but they are kind of like cats. You know, if you're really nice to them, they swat you. If you're sort of mean to them, they think about swatting you, but they don't. If you're really mean to them, they will get mad and they'll go find new owners. And so, you know, there's a balance that you do with working with orthopedic surgeons, and if I can give you 3 or 4 take-home points for the afternoon, there are certain words that they use that you don't automatically use. And if I introduce those for you, it's kind of nice. So now we're going to start with the lateral ankle ligaments, and anterior talofibular, calcaneofibular, and posterior talofibular ligaments are the lateral stabilizers of the ankle. At MR, these are all visible, and I don't use those in a trauma setting, but they are absolutely visible, and we talk about those on every single MR of the ankle that we discuss. When you have a lateral ankle sprain, the first ligament that usually tears is the anterior talofibular ligament. The second ligament that tears is often the calcaneofibular ligament, and the posterior talofibular ligament is uncommonly torn. Here is a public domain description talking about the medial side of the ankle, and the important point here with the medial ankle is that the deltoid ligament is a 2-component ligament. There is a long, broad, fan-shaped structure that is superficial. It's what you would see if you were dissecting from the outside, and then deep between the tibia and the tibia, the medial malleolus of the tibia, and the medial edge of the talus is a fan-like deep component. And so there are, at a basic level, there are 2 levels to the deltoid ligament, and then if you're a splitter, there are a whole bunch of components to the superficial part of the deltoid ligament. Now, between the tibia and the fibula, there are several ligaments as well. There is the anterior tibio-fibular ligament, and if you look here out in front, the anterior tibio-fibular ligament. There is in back the posterior tibio-fibular ligament, and then there is a thickening of the syndesmosis called the inferior tibio-fibular ligament. And when you look from the lateral, you can kind of see these structures. There's the anterior tib-fib ligament and the posterior tib-fib ligament. The interosseous ligament runs on up the space between the tibia and the fibula, and that is important when we get to Maisonneuve injuries. Now, all ankles that break can be classified, and all of the classifications come in one of 2 varieties. The 3-part classification, which is a variation from barely busted to badly broken, and all classifications that end up with 3 groups are just variations of the ways to say that, prettied up so that they were published at some point in time. Then there are the classifications by the splitters of the world, which have elaborate classification systems and are, for all practical purposes, very, very, very difficult to use. In the ankle, we have sort of the same thing. There are reasons for each of these. The one that strikes dread in everyone is Lauge-Hansen. And this classification is useful because it talks about mechanism of injury and gives a predictable set of failed components depending upon what you see radiographically. The downside is it uses lots of terms and is very hard to remember, just straight up. I'll show it to you, and I'll even ask you a question about it on the SAMs. But in practical purposes, this is a difficult classification for us to use because we don't tend to fix the fractures ourselves. The Weber classification, if you like to use the W with a V, or the Danis Weber classification, if you're from Central America, is the classification that's real easy to use, and I'll show you that one as well, and I kind of like that. The AO classification is overwhelmingly complicated with 27 different subtypes for any given ankle fracture, and therefore only really used in a research setting. It's a very good classification. You can reproducibly classify, but you end up with just too hard to work with in real life. Now, just guiding principles for what makes sense in life. The ankle has a ring-like structure based on ligaments and the bones that support them. And if you break the ring in 2 places, you have an unstable. If you break the ring in 1 place, you have a stable injury. Now, the Weber classification is easier. It's most classifications sort of come in that 3-flavor variety. This one is no different, A, B, and C. Type A is a fracture below the ankle. Type B is a fracture below the plafond, or the roof of the ankle mortise, the bottom of the tibia. Type Bs are at the ankle joint or the plafond, and type Cs are higher. And here is an example of each of those. A type A fracture is the distal fibular tip fracture. You guys are familiar with them as just the lower ones. You can have either a comminuted or an obliquely oriented fracture that begins at the level of the plafond. That's an interesting word because the orthopods like to use it, and it actually means the roof formed by the floor of something else. So you come down and the bottom of the tibia ends up being the roof of the mortise, and that's called the plafond. Now, a Weber C fracture goes on up and higher. This is intrinsically an unstable injury. This can be stable or unstable. When it's this wide medially, it's definitely an unstable fracture. Now, the Lauge-Hansen Classification was useful because it uses 2-word descriptors. The first one refers to the position of the foot at time of injury. The second to the motion of the foot, the talus, with respect to the leg. Now, a personal point of a mnemonic, supination and pronation are hard things to remember. And this is not accurate, and if there are podiatrists in the room, I'm acknowledging it's not accurate. But supination and inversion are sort of similar. Enough similar that I use the mnemonic sin in the feet. And I don't know how you work that into your own mind, but sin is easy to remember, and supination inversion is a mnemonic that'll keep you going that way, and pronation is the opposite. And so when you roll your foot in the way you would normally fall off of a curb, you are supinating your foot. You're inverting your foot. Now the motion, the second motion, is adduction, going away, abduction, going toward, external rotation, and that's the talus rotating outward with respect to the ankle, or dorsiflexion. Now there are stages to each Lauge-Hansen classification, and that is kind of at the level of how badly have you broken given that you were in this position and turning this particular way. So what you end up with is 5 different nomenclatures that come up with supination, adduction, supination, external rotation, et cetera, et cetera. Right off the bat, you're going, wow, that's an awful lot of thinking. And that Weber classification sure is seeming easier because I can say A, B, or C. And I'll tell you, in regular practice, what I do, I don't use this classification in terms of speaking unless it's one of a couple that are they kind of stand out. I will give all of the pertinent information so that an orthopedic surgeon could read my report, the body of the report, and make up their own mind, and with a high likelihood, come up with the same classification that we would come to if we were looking at it together. So supination adduction is kind of an easier one because it's the classic horizontal cleavage fracture that tends to be a Weber A, and the medial oblique fracture of the medial malleolus. And what ends up happening is you invert the foot, again realizing that I'm using a loose term for supination there, and then you move the talus medially toward the center of the body. The first stage that happens is you either break the ligament or you break the bone. The second stage is that you impact against the bone and you cause an oblique fracture of the medial malleolus. Realize, as we get to talking later, medial osteochondral talar dome injuries, which we'll come back to at a later point, happen because of this impaction here. And that's an important injury that tends to get overlooked. Here is a Weber A, if you will, a horizontal below the plafond fracture, or a supination adduction, stage 1. And so you've got breakage here, but you haven't broken medially. The next type that we'll talk about is a supination external rotation. And this is a fracture. If you read for the ER, you've seen one of these in the last 3 days. I mean, they're just so common. And what ends up happening is that you twist the foot outward with the foot in an inverted position at the beginning if you go with that notion of inversion and following with supination. The first thing that happens is that you tear either the anterior tibio-fibular ligament or you break the bone. The second thing that happens is that you'll stretch this ligament and then you will break the bone, and then the third stage you will come around back and chip off the posterior malleolus, that's the part that's right here, and then you will either open up the medial clear space or end up with a fracture obliquely here. This oblique fracture could actually be a horizontal pull fracture as well due to traction. So this is a Weber B fracture. You can, if we want to talk about stable, unstable, this is clearly unstable because we have multiple breaks in the ring. It's subluxed and working on a dislocation. But the fracture line begins at the level of the plafond and extends upward. The medial malleolus has pulled off, and when you look back here, on these particular injuries, there has to be a posterior malleolar component. And when you look at it here, this is in fact a trimalleolar fracture, if you will, or an unstable fracture of the ankle. I mean, the terminology at the point, once you've made the decision that you're going to call it an unstable fracture, the classification is more for fun. Now, the next possibility is pronation, meaning the foot was not supinated, so it was everted, and then abduction. And I'm not sure how you get this injury. I think you could trip and fall and go down with your foot dragging behind you would probably be the easiest way. The way that I imagine it happening is you're trying to stop yourself on your motorcycle, you put your foot down and it stops. And you then will tear or fracture on the medial side of the ankle first. So the deltoid ligament will either rupture or you will shear off the medial malleolus with a horizontal orientation. As you progress through the next stages, you will then impact against the fibula, causing a fracture, or you will tear the ligament or both. And so you end up with these various stages in the pronation abduction category. Now I'm going to tell you the last one, the pronation external rotation, and this is one that I occasionally will say by name because it has such a characteristic appearance. As you go through an external rotation, you start by pulling off the medial malleolus. You then will tear the anterior tibio-fibular ligament. You extend the tear into the syndesmosis, and you crack high. It's a Weber C fracture. And then the last thing that can happen is the lateral talar dome can roll all the way around and push off the posterior malleolus. And so this ends up being a trimalleolar fracture as well, a Weber C fracture, or a pronation external rotation stage 4 injury. So here you have a fracture, and at first blush, you look at this and you go, So you have an avulsive component here. There's clearly widening of the medial clear space, and we can discuss and or debate whether or not this is a widened tibio-fibular syndesmotic clear space. I don't have a good rule of thumb for that. I know that after you look at a bunch of them, and we've probably all looked at a bunch of them, sometimes they are hard to detect, sometimes they are fairly easy to detect. What I do know is that if you cone the image down, you can hide the actual abnormality. But when you go back and you see that there is a chip fracture of the posterior malleolus, you go, it's a bigger injury than just a tiny little flake here. So you get the cone, the expanded view, and all of a sudden you see the higher fibular fracture. So this is a Weber C, which is probably what I would dictate if I were going down the pile in the emergency room cases, or a pronation external rotation type 4 injury. Now you can compare the two. You have if you look across the top, this is a Weber type A, a Weber type B, or a Weber type C. In the Weber type A, you end up with a supination adduction injury where you pull off horizontally. You see it up here. You can end up in the Weber C, you end up with a pronation external rotation type injury, so these have a 1-to-1 correlation. However, in the Weber Bs, you either have that kind of cleavage plane oblique fibular fracture we've all seen over and over again, or the more comminuted fracture at the level of the plafond, and you end up either with a supination external rotation injury here on the left, or a pronation abduction injury there on the right. And that's all neat while you have a diagram in front of you, and what ends up happening is these Weber B fractures, I don't try to figure out which one they are because I have to go get the paper. I mean, when I'm reviewing for a lecture, I've read it and reread it, but in real life, I just call those Weber Bs. This one I'll occasionally call a pronation external rotation because it just seemed reasonable to memorize that one. Now, here's the AO classification, and this is just for sport. You can have fibular fracture below the syndesmosis, that's a Weber A, and then you can have 3 subcategories of that. You can have it at the level of the syndesmosis, that's also known as a Weber B, but you can have 3 subcategories underneath that. Then you can have above the syndesmosis, and you can have 3 subcategories of that, so you now end up with all of these various types, and the inter-observer variability in real-life situations, meaning those of us who look at x-rays and talk to emergency room doctors, becomes unacceptably low. Now, there are some less common fractures that are interesting because they will show up if you notice them. And these are fun if you like to use eponyms. I tend not to use eponyms. The need to look smart for my emergency room physicians is sort of waxing and waning. The fact that I read a film fast is far more important than I use words that forces them to go look in the dictionary. There's not a big bang for that. And if you're working with orthopods, they are far more interested that you never, ever, ever make a mistake. They are appreciative that you hit home runs every once in a while once they've determined that you're smart. If they're not made up their mind, a single screw-up makes you dumb forever. And so, I mean, that's just the way they are. So if you use the classification system and you cause them emotional anxiety because they might have classified it differently, they are unwilling to entertain the notion you might know more about the classification than they do, and they just call you stupid. If you are right 100 times, it takes an awful lot of rights to get them to agree that you're really pretty bright. So I'm of the false, I don't even know if that's a false negative or a false positive, an ortho disagreement situation. So I just describe them and let them do the classifications. Now, if you tear the anterior tibio-fibular ligament at the tibial tubercle, you end up with something called a Tillaux fracture. If you want to be of the centimeter variety, you call it the Tillaux-Chaput fracture. You can also get the opposite of that, and you end up with something called a Lefort fracture. If you're not talking about the face, you can call it the Lefort-Wagstaff fracture. And so these are variations that come into play when you see them. And here is one, now made obvious because this is a follow-up injury, and you now see the corticated fragment. We missed this the first time through, but there is an avulsion of the anterior lateral tibial tubercle in an adolescent, and we went forward that way. Now, Maisonneuve fractures, you've heard about these. They're actually kind of common. And whenever you see widening or irregularity at the ankle and you can't find all the fractures to explain everything, get a proximal fibular fracture or fibular image. And what this is a pronation, external rotation, type 4 that's gone really, really, really high. It's a fracture gone wild if you watch those videos. And so it's way up high and it goes to the proximal fibula. And the kind of angle is that, when you externally rotate and put a torque on the fibula, you can just tear along the syndesmosis. These are notoriously hard if you go just by the clear space. What I end up doing in real life is the ER docs are pretty good about if the patient won't bear weight and we don't see anything down low, they tend to reach up and feel at the fibula, and if it's tender proximally and laterally, they'll get the extra image. And here you can see a very subtle proximal fibular fracture. And if you guys are like me, just in a practical sense, tib-fib studies tend to be normal. I mean, I don't know how many people in here read in the emergency room, but tib-fibs, just like T-spines in 20-year-olds, tend to be normal. So the big game here is not to miss the subtle fibular fracture, which is right there, because at some point someone will blow it up really, really big like that, and then it gets a whole lot more obvious. And that's just frustrating to find it, when somebody else is showing it in a large format. But it is one of those things that if there's a fracture, if there's injury at the ankle, be aware of the Maisonneuve. Now I'm going to shift gears, and I'm going to talk about a fracture that's unique to adolescent individuals. That is the triplane fracture. And this is a fracture that occurs because the growth plate of the distal tibia closes or scars off in kind of a unique way. If you look at the right side of the image and you stare at 12 and a half years old, you notice that there is this bump in the tibial growth plate. That's called the hump of Kump, if you like mnemonics that have alliteration, I guess, or whatever that assonance it is, that goes with that. But the scar starts here. It goes medially first, and then it fills in laterally. So if you sequentially follow from the upper left to the upper right, you see the medial scar physis has closed off. You then come down and you progressively get scarring toward the lateral aspect of the distal tibia. This sets up a unique situation. In kids, growth plates, particularly as they are amping up their growth to scar off, are the weakest link. And in this particular case, you have a bone that is differentially weakened by growth plate activation. And so you end up with the possibility at around 12 to 14 years of age where these kids can come up with, you have scarred medially, you're open laterally, and so you can end up with what's called a triplane fracture. And the reason for the triplane fracture is that there is an epiphyseal component, which tends to be sagittal. There is a horizontal or axial component, which is going through the growth plate. And then there is a coronal component that always goes up and out the back. So in this particular picture, we're looking at a triplane fracture. This is the back of the patient. This is the front of the kid. There is the posterior coronal plane fracture, the axial physeal component of the fracture. And while we don't have it turned right, this is a sagittal plane fracture. Now there are a distinction, 2-part and 3-part, in triplane fractures, and that's depending upon whether or not the epiphysis has broken and gone with the medial malleolus, or whether it is broken off as a separate piece. Now, if you start looking for these, you will see them. They are not hard to see, but they are annoyingly subtle at times, and I have missed these injuries. The clue is when you have a fracture line that you can see through the epiphysis. And this one is following the rules exactly. There is the hump of Kump. The medial malleolus has scarred off, so you don't fracture on this side. The sagittal plane fracture shows up real nice. The axial component of the fracture is here. It stands there. Now, on the frontal view, you cannot see the posterior coronal plane fracture, but when you get to the oblique view, you've got it right here. Now, when you do a CT, it shows up a whole lot nicer. And here we've got a nice CT showing the coronal plane oblique fracture through the posterior metaphysis, the axial horizontal component, and then if you have the coronal fracture line, then you can see how it comes in. This one runs in, a sagittal fracture line running through the epiphysis. This is technically a Salter-Harris type 4 injury. You know, it's got metaphyseal component, growth plate component, and epiphyseal component. A 2-part fracture just has 2 lines running here, whereas if you have a 3-part fracture, from the radiographic component, it is very difficult to distinguish. This one looks an awful lot like the other one. There is the sagittal plane epiphyseal fracture. There's the slight asymmetric widening of the lateral growth plate, which I wouldn't call other than I know it has to be there because there is an oblique coronal plane posterior fracture. Here's the right side for comparison, which is nice when you have a difficulty, but with that vertical fracture line, it really shines out. Now this one is different. You see how there's a second fracture line that comes across here? So you end up with the posterior piece, which is this piece back here. You end up with the large shaft anterior piece, which is this piece here, and the epiphyseal lateral component has cracked off as a separate piece, and this is a 3-part triplane fracture. That is important for the surgeons. So if there's a take-home point, this does not happen to be in the SAMs, but if there's a take-home point, when you come across a triplane fracture, it is legitimate to work with your orthopedic surgeons to say, do you want me to get a CT to decide whether it's a 2-part or a 3-part? Because the 3 parts tend to be fixed surgically far more often than the 2 parts. We're going to come through the ankle fractures, then we'll talk a little bit about osteochondral lesions. Ankle fractures that we've been talking about so far are twisting, falling over curb fractures. You know, you get your foot caught in something, you go down, there's a twisting, there's a pivoting. We talked about all of those mechanisms. You can also fracture your ankle through a high energy deceleration. The best example of this would be you are forced to jump out of the 2nd-story window of a house, and when you landed, it wasn't your calcaneus that failed, we'll talk about that later, but in fact the talus shatters. And this is called a Pilon fracture or a Pilon. It's a French word, in fact, and if you want to say it properly and raise the eyebrows of your coworkers, it is true to call it a Pilon fracture. Now, you know, then you have to start saying centimeter all the time too. Now that having been said, these are a different animal altogether than the ankle fractures we've talked about. You don't get these by falling off a curb. You get these by smashing your foot, your talus, into the distal tibia with high velocity. And the bones, particularly the tibia and the fibula, they have a viscoelastic component, which is a fancy way to say that they break different when you load them slowly compared to when you load them rapidly. And the analogy that I've used in the past, and it sort of still works, is that of the spork. And I don't know, you've been somewhere and they've given you the plastic spork to eat your meal with, and I have kids, so we do all sorts of things with sporks. We flick butter at each other and things like that. But if you take a spork and you bend it slowly, it will deform, and it won't go back to its normal shape, but it won't crack. If you bend a spork rapidly, or you put it in the refrigerator at first just to increase your odds, it'll shatter into a bunch of different pieces. Now, your bones aren't quite exactly like a spork, but the high energy deposition during axial loading from a fall or a car crash or a fall from a height, all of the things that give rapid energy deposition will lead to these things called pilon fractures. Now, you can classify these, and Rüedi and Allgöwer have talked about a three-part classification. One is a single undisplaced fracture line through the pilon. Two, or B, is a sort of comminuted, little bit of vertical step off. There's some disruption of the articular surface. And then 3 is a markedly comminuted distal end of the tibia. And this is just yet again a variation of barely busted to badly broken. Now that's an easy classification to use. You can include these even more so with the AO classification that goes into all sorts of subcategories. But the take-home point is that all of these injuries are bad. The energy involved was much higher. The outcomes are far worse than with ankle fractures, and the more comminuted that you have, like over here, the more rapidly the energy was imparted to the ankle, and so these people have soft tissue injuries that confound the healing of the bones, and those people do quite badly, even if all the pieces were still where they were supposed to be. Now, the last thing I want to talk about on the ankle is osteochondral injury. The reason I include these here is that in my own practice, my own life, being someone who stares at these, I miss these injuries. They are notoriously subtle. And my rule of thumb is that when somebody gets evaluated for a potential ankle fracture in the ER, comes back a week or 10 days later and says they still hurt, I work from the assumption in my mind that they have an osteochondral injury, and if I can't see it, I even sometimes, depending upon whether or not I think there's some secondary gain going on with the workman's comp angle, I will say, if you guys are worried about an osteochondral injury, go get an MR to be able to see it. So here we've got somebody, and if you look at it, the medial talar dome is somewhat lucent compared to the lateral side. Now, this is not an obvious finding. This is something you could easily blow by, particularly, if I weren't sitting there putting an arrow around it and going back and forth like this. Blow it up, it doesn't even get that much better. There's a little bit of lucency. Now when you get the MR, you go, holy mackerel. So MR points out just how big these can be, and these are subtle injuries. When you look at them in the oblique view, they're pretty big that way. They tend to occur anterior laterally and posteromedially, and that goes along with the rotational component that goes here. So here you have a talar dome lesion anterior lateral with the edema, and in the same person, you have a posteromedial osteochondral defect. So in summary, ankle fractures are common. We see them all in the emergency room. Some of them are broken, a lot of them aren't. There's a lot of lateral ankle sprain, which tends to be the anterior tibio-fibular ligament in conjunction with the calcaneofibular ligament that get injured. If you have a fracture, you can classify them. There are different ways to classify. The Lauge-Hansen Classification is interesting. It's mechanistic. It's a tried and true classification that's sort of hard to use. The Weber classification is far easier because it's just the 3 types. But if you begin to use the terms that allow the orthopods to make the all-truth decision later on, you will find that they think your reports are better. And in just a very practical standpoint, when the ER doc has to call the orthopod, and where I work, if it's broken, the ER doc makes a call to the orthopod. The more that they are able to sound erudite when they are reading your report to them, the more they will like you, the better your relationship is and how it goes.